Tonight we're joined by Dr. Peter West-Oram. Peter West-Oram is a lecturer in bioethics at BSMS, where he's been based since 2017. He's a political philosopher and bioethicist whose work combines applied research into public health bioethics practice and policy with theoretical questions relating to global justice and ethical theory. Without further ado, I'll hand over to Peter. Over to you.
Thanks very much, Zach, and good evening, everyone. Thank you for joining us this evening. It's really nice to be talking to you all tonight. As Zach has said, my name is Pete West-Oram. I'm a lecturer in bioethics at Brighton, Sussex Medical School, and tonight my talk is entitled Solidarity in Healthcare and Global Health. My work at the medical school focuses mainly on the core questions of my research, looking at the nature of our obligations to other people. So what we have to do for other people, which other people, when, why, and sometimes why not. I'm also involved in the undergraduate and postgraduate curriculum, where I do teaching in questions relating to medical ethics and bioethics, as well as wider questions in philosophy more generally. And I'm particularly interested in my research, as the title of my talk suggests, in questions relating to solidarity, which I'll talk about in a little while, and ethical and justice questions in health, healthcare, and global health. So, as I say, the main questions of my research look at what we have to do for other people and why in health. And on top of that, I also chair the BSMS Research Governance and Ethics Committee. So tonight, my talk is structured around two key themes. The first is looking at the idea of our responsibilities or obligations or duties to other people, and with a specific focus on a duty to avoid causing harm to other people. And in doing so, I'm going to look at what we might be tempted to think of as a relatively uncontroversial or easily fulfilled duty, and argue that it's actually quite a lot more complicated and demanding than we may initially think, and talk about how that creates some challenges in healthcare provision and global health more broadly. And having done so, I'm going to suggest that one of the ways that we might be able to start thinking about responding to those challenges is to frame our thinking in terms of solidarity and the way in which we have relationships with other people at the individual, institutional, and global level. So I'm going to be focusing particularly on some of the challenges raised during the COVID pandemic, and then go on to talk about how solidarity functions in health and healthcare, and what that means for our responsibilities to other people. So the first part of the talk, as I say, is looking at this idea of what it means to have duties to other people in the healthcare context. It's tempting sometimes to think that while it can be quite a contested problem, and there is an extensive literature on the challenges of our responsibilities to other people, that it can be easier to think that a duty to avoid causing harm to other people is simple or easy or uncontroversial. Working in a medical school, something that often gets discussed, or something that people are often familiar with, is this idea from the Hippocratic Oath that we should first do no harm, or that physicians' primary responsibility is to first do no harm to their patients and to society as a whole. And this is obviously a hugely important suggestion, and it's something that is at the core of an awful lot of what ethical practice is in medicine. Equally, within a textbook or a book that is quite prominent in the bioethics literature on what we should be doing in biomedical ethics, one of the key responsibilities is this idea of non-malevolence, and this is suggested by Tom Beecham and James Childress, who suggest these ideas of four key principles in biomedical ethics. So we have these very prominent ideas of what it means that we have to do for other people, or what do we not have to do for other people. And equally, we see in the wide-ranging debate on justice more widely, these a range of responsibilities that are owed. The list on the right-hand side of the slide there, to avoid depriving, to protect from deprivation, and to aid the deprived, was categorized by Henry Shue, a philosopher, in thinking about the idea of basic rights, of what we are guaranteed to be entitled if nothing else holds. And these duties are wide-ranging and quite complex, but this key idea of a duty to avoid causing harm to other people is absolutely core to that project and to that model, But equally, Shu suggests that it isn't quite as simple as simply not doing bad things to other people. However, it does remain a little bit intuitively appealing to think that it's simpler than the duties to protect other people from deprivation or to aid the deprived. Though these other duties can sometimes be contested or controversial because they might seem to require more of us than some people may wish to do, and they might seem to extend more widely than people may sometimes think that they should. So we end up in a situation where the exact nature of our responsibilities to other people can be contested or debated or disputed. We might think, conversely, we might think that it's easier to think that avoiding harm to other people is relatively simple and straightforward. In response to that idea, however, we can start thinking about various ways that harm can be caused to people through our actions or inaction in ways that aren't immediately obvious. So the quote on the slide there are, "Most humdrum activities may harm people in ways that we have never thought about before." This is from Judith Lichtenberg's paper on negative duties, positive duties, and the new harms. So when we think about a duty to avoid causing harm, it might be tempting to think that this focuses only on things like deliberate cruelty or deliberate attempts to inflict harm on other people. So murder and theft and these other kinds of malicious actions, the things that are captured by that demand that physicians and first do no harm, or that we have a responsibility to avoid malevolent action more generally. What Lichtenberg suggests, however, is that while these things are certainly significant, there are plenty of ways that harm is caused without an intent or without necessarily even knowing that harm can be inflicted on other people. So she suggests that as well as malevolence, harm can also be caused by negligence. It doesn't matter if someone is deliberately desiring of causing harm if they get behind the wheel of a car while intoxicated. They can still do incredible harm to other people, even if they're not intending to do so, or even if they're not necessarily fully competently aware that they are doing so. Similarly, someone might not be deliberately wanting to inflict harm on people when they ignore safety procedures or safety policy, but it can still cause significant harm to vulnerable persons if rules aren't followed carefully. And then again, we can think of ways in which policy can be enacted at a systematic level where there isn't necessarily a deliberate intention to cause harm to vulnerable persons or to anyone, but through carelessness or through partiality or a desire to favor one group or individual over other persons, we might still cause harm to other people as a side effect of seeking to benefit others unfairly. So there's lots of different ways that harm can be caused, even if there isn't someone necessarily wanting to cause harm or wanting to inflict unjust or unethical damage to other people. And in response to this sort of sifting through or grading out these different ways in which harm can be caused through malevolence or through negligence or partiality, we might think of ways of sort of fine-graining the duty to avoid causing harm a little more carefully so that we can be a bit more accurate about what it is that we mean when we say we have a duty to avoid causing harm to others. So we can think of this as having the subcategories, if you will, or a slightly more precise definition of what it means when we say you have a duty not to cause harm to people. And we can say, first of all, like Beecham and Childress, like the Hippocratic Oath, there is a duty of non-malevolence. So passivity or restraint in the face of opportunities to cause harm. Don't steal from people, don't be unpleasant to them. That's relatively clear and often sometimes what we might think of as being intuitively obvious when we're talking about a responsibility or a duty to avoid causing harm to people. More demandingly, however, we can also start thinking about a duty to be conscientious. And through that, so adherence to guidelines, care about the consequences of our actions, being precise and careful when we are engaging in behavior that might pose risks to others, and adhering to the rules when we're doing something that might be dangerous. So this adds another layer of active responsibility. Rather than simply not doing deliberately bad things, we have to be careful and conscientious about the consequences of our actions when they might affect other people. Similarly, when we're looking at a structural level or a systematic level, we might need to be thinking as well about a duty of impartiality, so that we don't inadvertently cause harm through prioritizing or preferencing a preferred group. So immediately, we also already have a kind of general complexity of the duty. We have to be aware that a duty to avoid causing harm to people is not simply don't do bad things, but it also requires us to be careful and impartial with the consequences of our actions and the likely consequences of not quite malicious actions, but not necessarily impartial actions when those actions might be damaging to other people. So we have this kind of general complexity of a duty more widely that applies, I think, in most cases where we might think we have a duty to avoid causing harm to other people. So we already have a situation where it isn't quite as simple as it might initially seem. We can also say, however, that a duty to avoid causing harm to others can get even more complicated in novel or unusual or new situations when there are particular wrinkles to it that we might lack information about. And this we can call it the duty's situational complexity. And this might differ from situation to situation. So we might have, while there will be general complexity about the duty, in new situations, the specifics might get even more complicated. And this can be divided into two broad types. The first is uncertainty. And this is particularly important in novel situations. So in situations where we're not quite sure the precise information about the situation, where it's something that is new. So the COVID-19 pandemic being an excellent example of this case, where we're not quite sure what the best response is. We know that something needs to be done, but we aren't necessarily clear what that will be. And that uncertainty can lead to difficulty in providing effective responses or effective fulfillment of a duty to avoid causing harm. This can also come up when there is uncertainty or disagreement surrounding the appropriate prioritization of different options. So if we think for a moment that we can have two possible courses of action or two things that we can avoid doing, but we can only avoid one of them and the other is an inevitable consequence of avoiding the first. In one situation, we can avoid causing the harm X, but in doing so, we might inadvertently allow the harm Y to happen and might be argued to be in some way responsible for Y happening. So we might be thought to have caused Y and therefore to be in some way failing our duty to avoid causing harm. So in here, we have this uncertainty over what we should prioritize, what it is that we should avoid doing when we can't avoid all the possible harms that we might be causing to other people. The second type, or the second problem type, is controversy. So this is where there is a disagreement about what harm is likely to happen, or whether there is any responsibility on any given individual's part, whether it's my problem that this harm will happen if I don't avoid doing a certain thing. So here we have a slightly different kind of problem, not through a lack of agreement about what we should do or lack of understanding of what the right thing to do is, but through a disagreement that there is something that needs to be done. So here we have a slightly more contentious political problem, which I'll illustrate in a moment. So the first type, that uncertainty problem, we can categorize broadly as a kind of principled agreement, but practical uncertainty. Yes, there's a problem. Yes, there's something that we need to do in order to avoid causing that harm. We know that harm will be caused in some ways, but we're not entirely sure what the right thing to do is because we don't really know all the things we need to know in order to avoid causing harm. And if you think back to early 2020, at the start of the COVID pandemic, there was a fairly high degree of uncertainty about modes of transmission of the virus. And in this situation, it was quite difficult to know how we can actually go about avoiding causing harm to others. If we don't know how to avoid transmission, it might be challenging to say how we can fulfill our duties to other people because we don't know what that fulfillment would look like. So here we can think of various things that we all engaged in, like social distancing or wearing face masks, washing our hands regularly. But there was a certain degree of uncertainty about which of those things was the most important, which of those things we should continue doing, which of those things didn't really work as effectively. And so it was potentially quite difficult in that situation to say, this is the thing that you should definitely do in order to avoid causing harm. So here, the challenge is working out exactly what it is that we should be doing in any given situation, because we're not quite sure how harm is caused, so we don't quite know how we avoid causing it. You'll also see on the slide there a picture of Rishi Sunak before he was Prime Minister in the Eat Out to Help Out campaign, which provided support to restaurants in order to encourage people to go back out and socialise and eat in restaurants. Now, it turns out that actually led to a significant uptick in transmission rates of COVID and in cases. But at the time, it was argued that to allow this significant industry in the UK to collapse by not subsidising the dining industry would cause larger harms in the economy more broadly. We might question the wisdom of that argument, but it was suggested that it was important to ensure that the economy stayed strong in order to provide funding for to avoid other types of harm, which might also be significant. So here we have this question about a disagreement about which harms we should avoid. So this is the uncertainty problem. We know that we have a duty to avoid causing harm, but we're not quite sure how we can avoid doing that. And we're not quite sure which harms we should prioritize avoiding, given that causing some harm might be inevitable. The second category of problem can get a bit more problematic or a bit more challenging to resolve, and it's divided into these two categories. So the type 2 problem, or type 2A, principled disagreement and practical refusal. Here we can have there is an understanding, or the objection is that there is no agreement that a specific person or that people do have a responsibility to avoid causing harm. So this is almost the kind of not my problem kind of argument. And we have some examples on the screen here. So on the left, we have a tweet from the actor Lawrence Fox, who argued that the idea that we should social distance and avoid socializing with other people was inappropriate, that this was an overextension of state power, and that this would cause harm to people by preventing them from socializing with their family and friends. So the argument here, not really my problem. Someone else has got to deal with the impacts of social distancing, because it's wrong to stop people socializing in this way. The gentleman in the middle is the subject of an article where he, near the start of the pandemic, spent an enormous amount of money buying up as much hand sanitizer as possible in order to profiteer off of selling it at an increased price, or an inflated price, when people were desperate to buy it. And here, this is an example of someone attempting to profit from a situation where many people were desperate. It turns out that he did eventually have to sell the hand sanitizer that he bought at cost price, so he didn't end up making a profit on it, but largely because of backlash on social media. Here we see a kind of an avoidance of an idea of I should not do that to avoid causing harm to people, and an engagement with, well, I can make money from this situation. And then again, on the right-hand side of the slide, we have Dominic Cummings and Boris Johnson and Donald Trump, who in various ways acted contrary to guidelines, or to so in the case of Dominic Cummings, driving from London to Durham when potentially COVID positive, when we weren't supposed to be travelling. In the case of Boris Johnson, Prime Minister at the time, holding parties in the garden at Number 10. Here we have situations where there seems to be a case of a failure to recognise that there is a responsibility to avoid causing harm to other people. So it's slightly different here. It isn't about uncertainty. It isn't about not being sure what the right thing to do is, but it's a rejection of the idea that there is a responsibility to engage in behaviour to minimise risk to other people, for all of the examples on this slide. I mentioned that the controversy problem can be divided into two different categories. And this is the slightly simpler or easier version of the problem. But we also have the type 2b. And this is the situation. This is kind of an extreme version of the the principled disagreement. Here, this is the kind of conspiratorial, radical skepticism and denialism about the risks of COVID, the presence of COVID, and an extreme distrust in institutions which are intended or designed or supposed to provide information and protection from threats to our health. So here we see various examples of protests against COVID lockdowns, against requirements for vaccination or against masking, grounded in a kind of conspiratorial thinking about what the risks are, and a denial that there is, in fact, a problem. So as it says on the slide, this is kind of an extreme version of that principled disagreement. It's not just a denial of a need or an obligation to engage in behavior to protect and avoid harming other people, but an active opposition to efforts to safeguard public health. And we can also think of this as coming in with various forms of vaccine skepticism or vaccine denialism or fear about public health efforts more broadly. So this isn't quite the same thing as, no, I don't have an obligation to engage in behaviors which safeguard other people. It's that plus a refusal to accept that there is any need to do that at all. So it isn't, no, that's somebody else's problem or somebody else's responsibility to engage in these ways. It is a fundamental rejection of the very idea that there is even a problem that might require action from anybody. So this is a kind of radical skepticism. And this was very common or quite common in social media, where we see various different discussion groups on various platforms of the seeing a conspiratorial thinking in these platforms, which was taken to have greater legitimacy than official institutions such as the WHO, such as the NHS, such as the United Nations, which was seen as lying or fraudulent or lacking in legitimacy. It's a way of, and through social media influence, this is a way of making it harder to understand what we needed to do for people who were trying to engage in good faith, because of the prevalence of this kind of conspiratorial thinking in social media more widely. So we have this problem. We have this extensive debate in the philosophical literature on what the nature and extent of our obligations are to other people. And while it's very difficult to work out, or it might be very difficult or contentious to agree on what we have to do to assist other people or protect other people, or it's traditionally seen as more complicated because they seem to involve more active behavior, what I'd like to suggest is that a duty to avoid causing harm is no less complicated. It can still be really difficult because we don't always know what the right thing to do is. We don't always know how to ensure that we are avoiding harm. We might have to choose between which harms to avoid. And we also need to reckon with the fact that some people will reject the idea that they have any responsibility to moderate their behavior to avoid causing harms to others. With some of these challenges, we have frameworks in place for responding to some of them. So the uncertainty challenge can be addressed in part, but not always, through relatively, not always, but often fairly well-respected institutional processes. So if we understand that there is something that needs to be done, we have some kind of shared language where we can communicate what the different responses might be. We might not always know, but through the acquisition of greater knowledge, through peer review, through scientific research, we can at least recognize that there is something that needs to be done, and eventually, if not always fast enough, get to a point where we have an understanding of the appropriate response. So this can provide us with some way of getting to a response to the uncertainty problem. Not always a perfect response, not always as quick as we might need it to be, but there is at least a process through which we can move towards an answer when we don't always know what the right thing to do is, simply through lack of information in a particular kind of context. It's a bit more complicated when we come to the controversy and principled disagreement side of that challenge. It's a little bit unfair to and as I'll say in a moment, it's fairly unfair to include the image of Charlie Day there from the TV show It's Always Sunny in Philadelphia, but it is he's a very funny actor, so I thought it would be good to include him. But the conspiratorial side of this debate is really quite challenging because there is no shared commitment, there is no shared understanding that we have a framework that we can trust. And without that common language of this is how we respond to uncertainty, it becomes very, very difficult to develop an understanding of what we can do in terms of practical policy responses in situations of uncertainty where there is an imminent challenge of how we need to avoid causing harm to other people. Equally, you may have seen there was extensive politicization of the idea of vaccines, of the idea of face masking, where it was seen as something, a political statement to refuse to participate in these kinds of things, partly due to very strong social and cultural identification with particular political positions. And this becomes very challenging to address in when you're trying to work out the practical responses to something like COVID-19, because these things can become very deeply felt, and the more they are challenged, they can become even more resistant to change. So how do we deal with this situation where it isn't a case of uncertainty, but flat out refusal to accept that there is a problem, or that flat out refusal to accept that there might be any kind of responsibility, because yelling at one another doesn't work and it can actually make the problem worse? It's been suggested, for example, and there is research to suggest that in places where there are vaccine mandates for primary school and secondary school participation, for example, mandates can actually entrench opposition to vaccines against very dangerous diseases. So there needs to be a way that we can recognize how we think about these kinds of problems and how we can respond when people refuse to accept a common language of trust in relevant institutions. For the rest of the talk, I'm going to be talking about how we might start to frame our thinking around this idea of solidarity. And I'll talk about what it means, what that concept is, what it means, and how we might, by framing our thinking around these terms, we might start to find ways to engage meaningfully with that side of the second category of the problem, the controversy side of the problem. So we have this idea of solidarity. It's prominent. It's increasingly prominent in the bioethics literature, but it is a term and a concept with a lengthy history. It's increasingly subject to a broad-ranging debate about what exactly it is that it means. And I have just a couple of definitions on the slide there. So according to Sally Schultz, a commitment to solidarity is a commitment to form relations to a cause with others and work with these others to achieve the end that will bring about wider social change. So for Schultz, solidarity is something that we do with other people in order to pursue a particular social objective. So often this is defined as closely connected to the idea of justice. For Bruce Jennings and Angus Dawson, they suggest that solidarity is what we do when we stand up for, stand up with, and stand up as other persons. So this is a progressively closer in identification with other people. If we're standing up for them, we're saying, hey, you can't do that, I'm going to help that you. If we stand up with them, we're standing side by side. And when we stand up as, we're saying that that person is the same as me and I'm the same as them, and we're going to work together. So again, it's something that is closely connected to this idea of collaborative effort. The definition I have in bold there is from Barbara Prainsack and Elena Books, who argue that solidarity is an enacted commitment to carry costs, financial, social, emotional, or otherwise, to assist others with whom a person or persons recognise similarity in a relevant respect. So all of these definitions are focused on this idea of collaborative action, of identification with other people. So recognition that we are similar to or the same as people with whom we engage in solidarity. And many of you will have seen recently discussions in the news surrounding strike action of various kinds in a number of different industries. So there are strikes in the NHS at the moment for nurses and doctors. The Communication Workers Union, the CWU, has been on strike, as have my own union, the University and College Union, who are the union for many people working in universities. Trade union action is a kind of classic example of solidarity in action, in solidarity in society. So there are a wide range of strikes recently, or have been a wide range of strikes recently in a number of professional sectors, including medics, academics, transport workers, nurses, postal workers, all representing the kind of action. And indeed, one of the biggest trade unions in the world was called Solidarity. And strike action is a classic form of solidaristic behavior. It's an action that people take at cost to themselves. They don't get paid when they're on strike, in order to protest various different things, whether that's pay or working conditions or equality or any of these kinds of things. So here, people who engage in strike action are engaging in solidarity with their fellow union members who are also going on strike. They are saying, I will incur costs to myself to assist you, and you are going to do the same for me. So here is a case where a very prominent case at the moment of solidarity in action in society. We've also seen it throughout the COVID-19 pandemic in a slightly different way. And some of these images are that you'll recognize from earlier in the talk. But when we are engaging in things like social distancing, when we are staying in isolation, when we are sick with COVID, when we wear face masks to go to the shops, when we wash our hands, when we do shopping for our neighbours, when we make sure that people who are isolating have groceries and are okay, we're engaging in solidarity, even if we're not necessarily consciously thinking that that's something that we do. We are actively doing something at cost to ourselves, potentially, in order to benefit other people because of a recognition that we are in a similar situation, that we are a similar kind of person. So this starts to give us an idea of the role of solidarity in health. We engage in lots of different ways in solidarity in order to support, assist our peers, our colleagues, our friends, our neighbours, and also to avoid causing harm to them. If we're social distancing, if we're wearing face masks, if we're staying home when we're sick, there's a cost to those things, but in doing so, we can help the people close to us. We also have definitions of solidarity that talk about the idea of solidarity serves to strengthen the weak. It's a way of people without power collaborating together in order to resist powerful institutions that they might not necessarily be able to resist otherwise. This is from Calhoun. Or we might see solidarity as, according to Jodie Dean, it's an ideal of a feminist coalition. Solidarity is something that we can do in order to support people around us against injustice. So as I say, we can see certain kinds of solidarity as being particularly prominent at the moment because of what is happening in society. We've seen the actions that people are taking during COVID. We've seen strike action. We've seen action from all of these different trade unions. But we can also see it in a number of different ways in slightly less justice-oriented groups. So people can engage in solidarity based on recognition of similarity for things that might not seem so obviously connected to society more broadly. So we might have recreational solidarity. We share similarities with people who support the same sports team or who play video games online with one another. And they might engage in solidarity in order to support their friends or peers, even if they've never met in person. And these can be really meaningful and deep solidarities for many people. We've also seen solidarity in various other factors, such as activism for medical activity. So ACT UP was the AIDS Coalition to Unleash Power in response to inaction by various governments at the height of the AIDS crisis. See Stonewall, a campaigning organisation for gay rights. We see solidarity in the original women's suffrage movement, as well as in the Black Lives Matter and Disability Pride and LGBT Pride and Trans Pride. So all of these organizations, all of these things are communities of solidarity where people collaborate and cooperate to support one another in the face of very difficult circumstances, and in doing so, engage in solidarity with one another. So this is really prominent. These are very prominent ways in which solidarity is enacted in society by a huge range of people. And then in health, arguably one of the most prominent or significant areas of solidarity or solidaristic institution in the UK is the NHS. It's funded through taxation, which is all of us paying to support one another. And the quote on the screen there from Nye Bevan, or often attributed to Nye Bevan, illness is neither an indulgence for which people have to pay, nor an offence for which they should be penalised, but a misfortune, the cost of which should be shared by the community. So at the heart of that principle is this idea that this is something that we have to engage in together because we are all similarly vulnerable. And in doing so, we share the costs so that no one is abandoned as a result of misfortune or ill health. So we carry costs for one another to support one another. So here we see solidarity as institutionally present fundamentally at the heart of the NHS as a principle which grounds the cooperative nature of that institution. So some key points before I move on. Solidarity is an active concept. It's something that we do. It isn't enough to simply feel empathy or sympathy for someone. Solidarity is something that is active and done and engaged in to help other people. It's also grounded in this idea of similarity and symmetry. We act in solidarity when we recognize that there are similarities with other people. And again, this ties into this idea of equality, that there isn't a power differential. It isn't about, I have power, so I will help this person who is different to me because they're powerless. It is an idea that the action is motivated by a recognition that the person in question is similar to ourselves. And as I've suggested already, solidarity can be incredibly powerful. It grounds one of the most prominent institutions in the UK, and it has supported and empowered incredibly significant and impactful organisations for health more widely. It has been suggested, however, that solidarity can be quite challenging when it's harder to engage in solidarity when the group is more difficult to see, where it's hard, where people are further away from us, where we don't feel as an obvious a connection. And so solidarity, it has been suggested, is easier when there are sort of deep features of the person, whether that's language, whether that's nationality or religion or something like that, which is deep at the core of who we consider ourselves to be. I'd like to suggest that that might be a little bit pessimistic, but thinking about solidarity can provide us with a way of responding to those controversy challenges that I mentioned earlier. So something I've suggested in a publication a few years ago was the idea that while there might be disagreement or reluctance to engage in cost sharing for healthcare in cases where people might have a preference to have no responsibilities to other people, that actually collaborative solidaristic approaches to healthcare provision, as are enacted in pretty much all wealthy countries, excluding the US, are typically significantly cheaper, are typically significantly more efficient, and typically have better health outcomes for than the US system, which is highly individualistic. So here, and I alluded to this with when I mentioned the NHS, the idea is that even if you might have a preference to be free of obligations to other people, it's actually cheaper and safer to make sure to cooperate with other people in the first instance, because of the efficiencies of a cooperative, solidarity-based system. And as I say, the US is unique or almost unique in most wealthy countries in having a highly individualized system. I've also suggested, and this is a paper that I published a few years ago with Elena Books, where we suggested that the idea that this is cheaper, this is safer, that focusing on a collaborative, solidaristic approach to global health, grounded in the understanding that certain things such as antimicrobial resistance, like climate change and pandemic disease, are so dangerous and cannot be addressed by individual nations or individual people acting on their own, that this should motivate action for solidarity for global health. So the argument here is very much a kind of, there is a self-interested reason to want to mitigate or ameliorate or remove the threat of factors like climate change, pandemic disease, and antimicrobial resistance. This should motivate cooperation, which should hopefully encourage an awareness of similarity, which hopefully would lead to solidarity, leading to a desire to engage in solidarity for global health. Haven't really seen that as much as we might hope in the COVID-19 pandemic, as we have seen in a number of instances, cases where or in quite a large number of instances where wealthier countries are hoarding vaccines and failing to share them adequately with poorer countries. So we see a distribution of access to vaccines for COVID, which charitably is internally solidaristic for individual wealthy countries, but completely lacking in solidarity for poorer countries that don't have the same buying power. So this idea of solidarity and cooperation is not an inevitable consequence of self-interest. And it can lead to, if misinterpreted or misapplied, it can lead to various countries failing to engage in sufficiently broad solidarity. But I would like to suggest that we might hope that with marketed correctly or explained appropriately, that this should motivate action for collaboration at the global scale. And we have seen some of this to a degree. So we have here a kind of response to that type 2A problem. Even if you don't feel that you have a responsibility to other people, it's probably or possibly going to be in your interest to help them because it makes you safer. It makes you have better off in terms of the cost of providing healthcare to other people. And the same applies at the national level. Resolving the controversy side of things is much more difficult. We don't have, if there isn't a shared acceptance that there is a problem, it's harder to convince people that it's in their interest to engage in cooperation because they don't recognize that there's a problem to be cooperated against. What we can do, however, is recognize the impact and the value of the communities that exist surrounding controversy, surrounding that conspiratorial thinking. So while it is perhaps tempting to dismiss the refusal of participation in things like vaccination programs, by recognizing where these things come from, by recognizing the quite legitimate fear of the medical profession as a result of, in some cases, decades of misbehavior, to put it mildly, by the pharmaceutical industry and the healthcare infrastructure, by recognizing that, by engaging with it meaningfully and seeing for certain communities where the fear, where the motivation for skepticism, where the motivation for a lack of trust comes from, and engaging with those solidarity groups substantively and not dismissing them, and recognizing what the value is of these communities for people who are skeptical and untrusting, we might start to be able to engage with them more constructively rather than dismissing them out of hand. It's much harder. But by recognizing the importance of the solidarities that do exist surrounding these narratives, we can start to engage more constructively. So just to wrap up, I've suggested that working out what we have to do for other people simply in terms of avoiding causing harm is a lot more complicated than we might be initially tempted to suspect. This can lead to a couple of different problems, and it can be challenging to work out how we can resolve them. One way of doing so is through, when it comes to uncertainty, is accepting that there will be a delay in novel circumstances where we have a difficulty of working out exactly what it is that we have to do because of a lack of knowledge. When it comes to that controversy side of the problem, emphasizing self-interest, emphasizing the value of engaging in cooperation might be one way of responding to rejections of those duties. When it comes to controversy, when it comes to the conspiratorial thinking or the rejection of institutions and norms, if we start to think in terms of solidarity and analyze what is going on in terms of the solidarity communities that exist surrounding that radical skepticism, we might be able to start engaging with those communities more meaningfully and get better engagement and respond to that controversy more effectively for individual, public, and global health. So, this is by no means a perfect solution, but it does give an overview of the kind of stuff that I work on, and it looks at some of the challenges when it comes to our theoretical understandings of the nature of our responsibilities to other people and how we might go about responding practically to those challenges. So I think that's my time. Thank you very much for joining us this evening. I hope it's been interesting. I look forward to your questions.
Excellent, thank you, Pete. That was really, really interesting and really well explained. If anybody has any questions whatsoever, please do pop them into the Q&A function. We're happy to try and get it through as many as possible in the next 10 minutes or so. So we've got a good question here, all about solidarity. Do you think solidarity will have an impact on campaigns for fair pay in the NHS and other campaigns?
I would certainly hope so, yes. I mean, I think we have seen that there are, when there is more solidarity engagement within and between trade unions, there tends to be more progress that is made. I mean, union action does tend to be more positive. I mean, one of the things I suppose in some ways I don't think calling it a cliche is uncharitable, I think, but when we think about things like weekends and holiday and parental leave and the limited hours on a work week, all of those things are the product of union action. Pensions are the result of union action. So all of these things are not things that were given. They were things that were achieved through solidarity amongst working people. So hopefully, when it comes, I'm hopeful. Though I know that it can seem challenging. It's certainly been challenging as someone who's been on strike quite a lot recently.
Great. We've got a question here from Nishad. Do you think solidarity and groups being hive-minded are different, or perhaps is the latter an extreme manifestation of the other?
That's a really interesting question. I suppose it depends a little on what we mean by hive-minded. So I'm assuming, and please feel free to correct me if I'm wrong, it's kind of everyone thinks kind of the same thing, and but please feel free to tell me if I'm wrong in the chat. I don't think it's necessarily the case that solidarity leads to that kind of groupthink kind of thing. I mean, anyone who's been in a union meeting will know that there is certainly disagreement about these things, and I think we can see in some ways we might say that any sort of state is a solidarity community because it's grounded in a recognition of identity in some ways. So within a democratic state, at least, you have significant disagreement within that community. So I don't think it's necessary. I'm perhaps misinterpreting the question, but I don't think that they are synonymous. But certainly you can have a solidarity group which is everyone has very similar opinions, and I don't think that's necessarily bad or wrong. And equally, you can have a solidarity group where people have very different opinions. I mean, one of the an example from Barbara Prainsack and Elena Books' book in their discussion of solidarity, which I think is great, is it can be related very closely to sort of things that we think of as very deep and innate to our identity, so nationality or language or religion or something. Or solidarity can be grounded in something like seeing someone on the bus and going, oh, I remember what it was like when I broke my leg. You can have my seat because you've got a broken leg at the moment. Or it can be, or being on a plane and you're both delayed and their mobile phone doesn't work, so you lend them your mobile phone so that they can call their family. And it can be very transitory, or it can be very deep and lasting. So I think there's a huge range of ways in which solidarity can function and be enacted.
I think that leads really, really nicely onto this question that we've got, and I think you've sort of answered it just then, but I'll put it out. How would you describe solidarity in simple terms?
That's a great question. I really like the Prensack and Book's definition. I mean, I think that in simple terms, I would say that it's what we do when. And it is something that we do, not something that we just feel. It's what we do when we are engaging with other people in some way because we recognize that they are like us, which is really just a kind of paraphrase of Barbara and Elena's definition. But I think it's hey, that person's like me, I can help them out, and it might have some cost, but that's fine.
Excellent. Yeah, no, I think that makes a lot of sense. I've got a good one here that's a little more complex. Can you explain a little more about the hierarchy of harm, if there is one? Do you think people have traditionally privileged physical harm over mental well-being when it comes to decision-making about treating different kinds of harm?
That is a great question. I'm hesitant to sort of suggest a hierarchy of harms because I don't want to because I don't want to say that something that I happen to not, that hasn't happened to me isn't as bad. But I think to answer the second part of the question, I think we can say reasonably that there are some things that are more like if breaking my arm is worse, I think, than getting a paper cut, probably. But that which seems a bit frivolous, but I think it gets rather difficult to start providing a hierarchy. But I do think that it would be fair to say that historically there has been a much greater preference given or prioritization or weighting given to physical harms, and we only need to look at the way in which mental health is still massively stigmatized in an awful lot of healthcare settings or more widely in society more widely. So there is improvement, I think, but I think it is fair to say that there has been historically an increased weighting or unjustified increased weighting on physical harms rather than harms to mental health.
So we've got quite a complex question here. There's elements of this that go over my head. So please let me know if you need any bits clarified. There seems to be deontological elements when it comes to avoiding harm. How would your theories differ under a utilitarian framework?
That's a great question. So for those who aren't sure, a deontological approach would be focused on duty or right action, and a utilitarian would be a consequentialist approach, so looking more at the outcomes and consequences of a given action. So the way I see this is it's fairly theory agnostic, in the sense that I think we can think about type harms and duties to avoid harm while there is a duty. There are consequentialist or utilitarian reasons to think about why we have a duty to avoid causing harm to other people, because it's harmful, because it's bad. I think if we were to frame it, and I think to an extent in practical terms, in policy terms, you're almost inevitably going to have a high degree of utilitarian consequentialist thinking, because it is about we have X resources and we need to do X plus Y action. So we have to pick things. So we have to think about things like opportunity costs, like a hierarchy of harm that we want to avoid. that I think would be, traditionally they are theoretically completely distinct, but I think in practical terms, in responding to things like COVID-19, they are inherent to those discussions because of resource constraints. Because we might say it would be the right thing to do X, Y, Z, but we might not have the resources to do X, Y, and Z, and we might therefore need to pick which of the three we do first, because of things like the consequences of picking them, which is kind of a vague answer, but to a really good question. But I hope I hope the person who asked it is happy with that answer.
I'm sure that they are. So I think that brings us to the end of the time that we have for our Q&A this evening. So thank you again to Pete for answering those questions and for your whole lecture this evening. So I think all that's left to say again is thank you everyone for coming along this evening. We will send out the recording of tonight's lecture as soon as possible. And thank you again to Dr. West-Oram for providing our lecture this evening. You can now head off and enjoy your evenings, folks. Thank you very much.
Thanks, everyone.